previous 6 months, year over year. Or startups that had search volume growing at least 100% in the same period, despite any impact that they might have going down, let's say, compared with their previous 6 months, year over year. The second category is actually what we're calling sustainable growth or sustained growth over time. And by that, we decided to have a minimum threshold of startups that are growing at least 30% in March and April 2020, despite any impacts compared to the previous 6 months, year over year. So basically, we're looking at a minimum growth of 30%. And of course, for the rocket growth, we're looking at startups that are growing even more and faster than that. So what's the landscape looking like, and how are Brazilians changing in terms of how they search? We try to create three pillars here, or look through three lenses to really understand what's happening. And we based ourselves a lot in several other studies that Google has released over the past couple of weeks, really going deep and understanding how consumers are changing behavior. And we tried to summarize into those three main pillars. First one is the change from want to need, and the increase in essential online purchases. And for that, we've seen that 38% said that they change, for example, their routine on how they prepare a meal, or they started to order more delivery more frequently. Second one is related to from out home to in-home learning. There's no doubt about it, and my friends from Stanford and Berkeley are here to confirm. The education system is one that is probably among the most affected ones in terms of how quickly they have to adapt and change, either from a student perspective or institution's perspective, parents' perspective when they think about their kids. So at least 65% of people in Brazil said that they are working or studying from home. And 18% said that they are planning on starting an online course. So we really want to deep dive into education as a new online education as a new habit. And of course, seeking for financial support. There's an increased search for financial aid. And that speaks a lot to the concern of at least 45% of connected Brazilians that had an impact and reduced their income before the end of March alone. So for the first pillar, we'll be looking at specific sectors that I'm going to show and going to deep dive for the next couple of slides. So when we look at changing from want to need, people really want to learn new recipes and cook their own food while at home. The interest for specific types of recipes and foods is increasing as families are spending more time together at home, cooking and eating together. Here's just a few examples of Brazilian dishes or Brazilian recipes that have really increased their growth in search over time, like brigadeiro, coxinha, pão de queijo, which is all very familiar to us. At the same time, people are also interested in, one, convenience, and second, staying safe during this period. So the social distance had a major effect, specifically on the delivery side or in the delivery growth that we can see on the search data. So adapting their new habits and routines to social distance, but with convenience and safety, is what we can see as a very clear trend. When we look or deep dive into the categories, which is something that I think it's where we start to see a lot more value, we can see, for example, that search related to food and beverage is growing between 30 and 45% when we look at after social distance period. And restaurant delivery alone increased to 72% in the same period of March and April 2020. That's when we start looking at startups, and the startups that are actually offering convenience and last mile delivery services, they really stood out in our analysis. So let's start with the ones that are the rocket startups. Here we found three startups, Melhor Envio, Zé Delivery, and Empório da Cerveja, that had amazing rocket growth over the period, as you can see from their growth percentages here, uh, as well as those who already have a really big search volume. And here you can find us indexing that for a 6 months average volume of search, in which really big players or really big startups such as iFood, Happy, and Logi, they sustained and even increased their growth that was already high over this average 6 months period in the current landscape of COVID-19 and social distancing. It's important to notice here, for example, that Zé Delivery and Emporio da Cerveja, they are actually two startups that are born and raised within Ambev or InBev. So they have, of course, some things that are in favor of them in terms of brand awareness and brand recognition. But at the same time, their growth has been spectacular when we look at the past few weeks, which really shows that, you know, like corporate investment in creating and fostering innovation is paying up in this specific situation for Ambev. So when we look at week by week growth, it's really interesting to see how people, for example, are changing their meal routines. You know, we can see here like Live Up. It's a startup that's focused on, you know, like healthy meals, how they are increasing their search volume in a specific period in time. They are decreasing over the next few weeks, but still sustaining a much higher standard or a much higher interest than pre-social distance times. And here it's interesting also to see, you know, like we have both indexes. One is for the startup index that I show you on the previous slide, but also we indexed to really show how Zé Delivery is doing, to make sure that, you know, like the graphic wouldn't look disproportionate between the different startups that are being shown here. So going next, people also want to be comfortable at home, either while they are working at home or if they are just staying longer at home and having to adapt their routines to that particular new situation. So we can see, for example, that specific searches for pieces of furniture like chairs, tables, and of course clothing, they have been growing consistently during the period of social distance. Despite spending more time at home, though, people also want to feel or stay and look good. So we can see, for example, here searches for makeup kit, let's say, they were growing 33%, which is already very significant growth year over year. And they have nearly doubled during the social distance period. When we look at the categories, which is where things start to get more interesting, we can see that furniture alone or home or working from home setup, you know, like furniture for home offices, as we say here in Brazil, only that particular category grew more than 90% when we look at March and April. And beauty really accelerated only after a few weeks of social distancing. And, you know, like, and now it's really going up, as we can see when we look at startups that are there. Those startups, they are really focused on those niche retail and marketplaces. And some of them are Pet Love, who is really focused on the pet market, which is amazing in terms of size. Beleza na Web is the same in terms of beauty. They are both the rockets in terms of growth, and the ones that have been sustaining growth over time, but without being less representative than the others, are Madeira, which is focused on furniture specific. We can see that only April and March, their growth has been of 70%. Mobly, which is similar in terms of what type of niche market they're serving, which is furniture. And then Glambox, which is also on the beauty category. And finally, Olis, which is actually a startup or a solution that helps other retailers come online on marketplaces across different types or different niches of markets. So all of those have seen or have grew a lot over the past couple of weeks. As we can see here, it's interesting to see that the real interest really rises after week 4 of social distancing. And these marketplaces have grown between 40 and 140% during that specific period of time. Now going to the adapt to new habits, and I'm going to go a little faster here due to time. So adapting to remote learning has been critical, and online classes and courses have been amongst the highest searches that we've been finding with, like really relevant peaks, as we can see here. More specifically, when we look at categories, searches related to educational software, for example, they have increased more than 40% during the social distance period. And online education and degree programs alone grew more than 70% over the same period in time. That's when we start to look at startups or platforms that are really supporting the remote learning experience and or providing digital content with quality for people to develop new skills while they are at home, but still connected. Here it's an interesting category because most of the startups that we found with significant growth are rockets, as you can see here. So we have the likes of Hotmart, Passei Direto, Studi, Me Salva, Geeky, Agenda Edu, and Clip Escola. All of them provide specific solutions, but they all experience very high growth during this period. And finally, Sanar, that provides a very specific type of online content or training for medicals that are actually preparing for residency, that really stood out and grew more than 100% over that same period in time. And when we look at how that performs week over week, we can see first a very clear peak after schools closure was announced. So startups like Geeky, Me Salva, and Studi, they really stood out, as well as, for example, Agenda Edu and Clip Escola, which are more focused on communication and connection between students, families, and schools. And others like, for example, Studi, that had a moment in which they announced a free Studi Gratis, that really paid off in terms of search growth. And of course, they suffered a little over time as they provide a solution that is mainly focused on ENEM, and ENEM has been postponed due to the COVID crisis in Brazil. And finally, seeking for financial support. And this is something I think that is super important when we look at not only the health but of course the economic impacts of COVID in Brazil. And despite the fact that those economic impacts are still unfolding and pretty much unknown, there is still a lot of influence that this situation will play in terms of how our financial long-term behaviors will consolidate from now on. One example here is government aid really influenced the search for conta digital or online account. And of course, after a peak of interest, when the aids were announced, search, of course, dropped, but really remained in a higher search interest than before, which is an interesting thing to look at. And also other specific terms that are growing tremendously when we compare search volume on April of this year and the previous 12 months. For example, internet banking been growing more than 130%. Abrir conta na Caixa 6 times compared to the previous period in time. Empréstimo consignado de INSS more than 400 times, and so on. So when we look at like how that has been performing in terms of categories, of course, online and mobile banking have increased a lot, but also categories like money transfers, wire transfers, personal lending and borrowing, which are categories that not all of them have relevant players in the startup ecosystem that we found to be relevant at this point. But fintechs, they really performed when we look at them against those categories I showed before. And despite the fact that they've been growing pretty consistently on average over time, they really sustained their year-over-year growth when you look at this period. And we have startups like PicPay, Husky, Olivia, Acordo Certo, and Catarse, which is actually a collective finance platform, to be growing a lot when we look at their performance over this past 2 months. But also startups like Hebel, Creditas, Neon, and SmartMay that have sustained a really high growth despite their previous already pretty high growth. Finally, there's two main or two specific points about Husky and Olivia. Those two terms are pretty common. Like Husky, people might be looking for the dog, or Olivia might be looking for a name of a person. But given the associated terms, and of course, given that there was no very clear reason for people to start looking so much more for either Huskies the dogs or Olivia as the person, we found that it's most likely to be related to the startups themselves. That's why they are part of our highlighted companies for this specific pillar of seeking financial support. And here we can see, like there's interest in all types of fintechs and platforms in general over time. And we can definitely see some of them that are peaking, like PicPay, over the weeks since March 1st. But overall, they already had been growing very strongly, even prior or previous to social distancing. Just to summarize, since we're coming to an end on our presentation, so if we could split or divide categories of the category of rocket growth in those three different, let's say, pillars or behaviors that we are seeing change, we would see on the left the ones that are considered to be the rockets, or that presented rocket or exponential growth, and on the right side, the ones that were already growing a lot and they sustained at least 30% of growth in the period of March and April 2020. And finally, I think there are some important takeaways. First one is, looking ahead, of course, startups will play an important role in how we transition faster than ever to a digital economy over the next couple of months and years. That said, of course, there are behaviors that are changing and they will continue to change. Therefore, search provides a very accurate measurement or photograph of how people are adapting to their new ways of living, their new routines. But despite the emerging trend that we've seen, it's still early days and we need more time and data to really say and predict which of those behaviors are consolidated and came to stay in people's lives over the next couple of years. Second is, growth retention is also essential for startups. Despite rising in search and despite the very clear interest from users and from consumers, sustaining or retaining that growth is critical for all companies and startups in particular. So focusing on consumer loyalty and success, and of course, providing the best user experience possible and really strengthening their brand efforts over time would definitely help them achieve and sustain that growth. And finally, making the leap or the jump from search interest to real market opportunities. We think startups are overall very well positioned. And of course, we know some of them are experiencing bumps and really difficult times to continue their operations given the current state of things. But we also believe that startups are well positioned, specifically in some sectors, to really be top of mind products and solutions to consumers. Therefore, the next challenge is to really turn that interest into market opportunity and market share. Finally, I would like to say we're going to be putting this presentation available publicly. There are very interesting insights, especially when we look at categories and startups that are serving against those categories that raise interest. but also categories that we found that we found to be growing, but we couldn't find any startup that was really growing as much as the category, and therefore there is an opportunity for startups in specific categories that we highlight in the study. So with no further ado, thank you so much, and I will give Diego the word from now.
Thank you, Andre and Marcus, for this insightful presentation. As Andre mentioned, the slide deck used in the presentation will be available on our website soon. In the first edition of Brazil at Silicon Valley, Lloyd Minor shared with us that the goal of precision health, in contrast with precision medicine, is to keep us healthy. It is to predict, prevent, and cure diseases precisely. He then claimed that in order to really move prevention forward, we have to be able to address the social, behavioral, and environmental determinants of health. This statement is even more relevant now in times of COVID-19. We will continue this discussion with the panel Health Tech and COVID-19, the Future of Healthcare, with Anurag Mairal, Adjunct Professor of Medicine and the Director of Global Outreach Programs at Stanford Byers Center for Biodesign at Stanford University, Carlos Bustamante, Venture Partner at F Prime Capital and Professor of Genetics and Biomedical Data Science at Stanford University, and Sumant Ramachandra, the Chief Technology Officer and President of Baxter Pharmaceuticals. The last 10 minutes of the panel will be a Q&A. Please send us your questions during the presentation on the Q&A, and we will make sure they get to the speakers. Without further ado, I'd like to welcome Anurag, Carlos, and Sumant. It's a pleasure to have you here. Dr. Anurag, please take it from here. Thank you.
Thank you, Diego. What a wonderful opportunity to have this conversation with two of the leaders in healthcare, one from academia and one from the industry. This is a very difficult time that during which we come together in virtual world, because that's the only way we can really at this moment. But it's a very important time for our society as well, as we contend with this very serious pandemic that is facing us, that we are going through, and that actually threatens to change pretty much everything that we know about our world or about our society, and not just the healthcare system. So although today's discussion will be primarily focused on healthcare and the impact of the pandemic on that, fact of the matter is this is probably the most serious crisis to hit our society, global society, in over 100 years. And the number of countries that have been impacted by this, the number of countries and territories are more than the members of the United Nations. And more than 200 countries and territories are going through this right now. Everybody's impacted by this, the rich and the poor, the old and the young, the ones with access to healthcare and ones without access to healthcare. So what we're going to do in today's discussion is get into some pretty significant questions, serious questions that may have provocative answers, and try and assess what does this crisis, what does this pandemic mean for our healthcare globally. We will talk a little bit about Brazil and the United States in particular, because those are the countries that are of greatest interest to us for this audience, but we will talk about the global perspective as well. So let me actually get into it right away without further ado. So, this is a question to both the panelists. This has been the crisis, as I said earlier, that has impacted all of us. And frankly, health systems are struggling all over the world, whether you're talking about China or Italy or parts of Latin America, Brazil included, or United States right here at home. Both of you, Carlos and Sumant, what's your prediction of when this crisis will end? Is there an end in sight, or will we be in this state forever?
So, Carlos, why don't you go first?
I was going to say the exact same thing.
So, okay, listen, Anurag is on with me at LinkedIn. I publish on these items quite a bit, just because I'm a immunologist, I'm a medical doctor, so I follow these trends. So a few things. One is that a pandemic is essentially a global epidemic in essence. Okay, that's how you think about it. Okay, and it's just a definitional issue between the two of crossing borders, gotten in the community. And this can quickly become an endemic over time. And you know, we have at least 4 known coronavirus strains floating through the population. They cause the common cold. About 1/4 of common cold is typically a coronavirus. Rhinovirus is another big one. And there's a few other ones that cause the common cold. So you wonder, if you look back in human history, maybe there were other coronaviruses that over time spread over the population. Okay, needless to say, the initial impact is quite high. And I've had this debate with several people because they don't understand why this is even a big deal. But if you take 7.8 billion people on Earth, and you say 60% of the population has to get exposed at some point, and you take a case fatality rate, that means of those infected, how many people die, and you use a 0.5%, you end up around 23 million people who have fatality. Okay. Now, let's say you say it's 1/5 of that. Is that still acceptable? So a lot of this discussion on public health has been focused on the sheer number of people that can get impacted when you don't have a vaccine or any known antiviral agent. And the ones that were hyped up, like hydroxychloroquine or chloroquine, more and more data. In fact, today, it's being questioned whether the initial Lancet study was problematic. Okay, was the data made up? And so we have to be careful because in any emerging disease, by nature of it being emerging, we always think we know more than we actually know. So we are finding out things along the way. The other thing is that any virus over time can mutate to the point that it gets not as contagious or less fatal in the population. So all these things. So none of us know what's going to happen in the future. What we do know is we have to actually plan for the worst and hope for the best. So if I were to play this out, I would say that we are looking at a potential few more waves. The protests and the mass gatherings that have been happening over the last few days globally, including in Europe and the United States predominantly, will probably increase the transmission rate by nature of the fact that people are together, people are screaming. When you actually shout, you actually get more aerosolized virus particles. And even if you have a face mask, you have your eyes exposed, which is another mucous membrane. So the question is, you know, how will this all play out? And once it embeds into a population, it tends to persist over time. So I would say that the way it would end is that over time, we're going to have to look for an antiviral, and remdesivir from Gilead appears to have at least some benefit in moderate and mild patient symptoms. And hopefully one of the many, many dozens and dozens of vaccines under study are going to have some effect in the population. So was that 6 months, 1 year, 2 years? I think it's definitely more than 6 months, probably less than 2 years. Carlos?
Yeah, no, I would agree with almost everything you said. I think I would add, you know, my background is as a population geneticist, having worked on both humans and pathogens. I would certainly ascribe to your notion that what we're seeing here is a global pandemic. It is a consequence of human activity that is likely not to cease, and so it probably won't be the last one we see. And just in our lifetime, just think about how HIV came into being and changed the practice of medicine, the impact Ebola has had most recently in terms of concerns around global pandemics and pathogens, Zika. So, you know, it's par for the course that as we are hammering into the environment, these things are coming back at us. And global travel and just contact has made it almost inevitable that we need to be prepared to handle this. And I would say, when's it over? Well, I would say hopefully we won't have to shut down again, you know, and we've learned how to get over some of that and sort of take stock and begin to make decisions. I would say that from a basic science point of view, if the flu had not been seen by humans and you introduced the flu, that'd be a big deal, right? That would be a big deal. And how long have we had the flu? Time immemorial. So I don't think coronaviruses go away. I think this becomes something we try to vaccinate against. One thing that's quite amazing about this disease, though, is that we are studying it very scientifically, as Osler would have taught us. We are finding the people that have the disease, not the other way around, right? And that has made a really big difference, because we've seen an important lesson, which is that people vary in how they respond. And that variation has to do with age. It may have some to do with genetics. It may have some to do with population exposure. And so we can't just think about the average, which is what gets us in trouble in medicine. We have to think about the tails and the most vulnerable and how we kind of build towards that. And I'm optimistic, actually, that this has just shaken many people to their core, many institutions to their core, many healthcare institutions to their core, and we want to do better and we want to do different. And I think that we will learn from this experience, and it will improve long-term how we deliver care, which is ultimately a good thing.
That's a great segue, Carlos, to the next question that I have. This is a novel coronavirus, as both of you pointed out. This has really taken us by surprise in many ways, and we have not done very well. Healthcare systems are struggling, as we talked about earlier. If you really think about, I'm a health technology innovator, and that's what I teach at Stanford. And I taught this course earlier this term, this year, in the winter term that Sumant spoke at, where we talked about how we need technologies, the drugs, vaccines, the diagnostics devices and tools, and digital health solutions, all to address global health challenges. This crisis was brewing in the background when I was teaching that class. And what has evolved since then, and this was the last lecture we did for my class, we talked about COVID-19, and we talked about how we failed at every front. And we still are struggling with many of those, whether we talk about diagnostics, whether we talk about devices, ventilators and things like that, whether we talk about drugs for the disease. It's a new disease, of course. And we are still not sure of the vaccines. We're going to have effective vaccines and what time period they're going to be here at. And contact tracing and other use of other digital technologies, which is a part of your focus, Carlos, as you think about data. That's been it's been a useful tool, but we've not done tremendously well so far. So can I ask you both a question about how, why were we so unprepared given so much that we know about virology, about we have had a robust healthcare system at least in the Western world for such a long time, or so we thought. Why has it taken us by surprise? And if you could kind of extend that and kind of talk about what sort of impact do you think it has had, the nature, and if you could quantify that, of that impact on our health system, both here in the US and Brazil and elsewhere.
I'm going to actually disagree a little bit and just say that, boy, I'm so happy that so many people have done so well. And so many places and so many people have worked so hard to shoulder into this thing, right? Like, the healthcare teams have done an admirable and incredible job. I think our delivery people have done an admirable and an incredible jobs. Our politicians aren't scientists. They've got a million things to deal with. They're honestly, almost all of them, trying to do the best they can. I do think we got ourselves a little bit into a box, partly because of our reliance on technology, to be honest. I think that had we tried to handle a pandemic 50, 60 years ago, we wouldn't have been able to diagnose with a lot of tests. And so we would have just had to kind of shuffle people around to kind of contain the infection. And so we tried to rely very heavily on testing, as one would, given the very technological nature of how we deliver care. Did we get it perfect? No, of course not. But I think the scientific community and the clinician community has just been spectacular in trying to get what works out there as fast as possible, as level-headed as possible, so that we can aggressively treat if we're learning things that work well, but first do no harm so that we don't hurt patients, because we're finding, like the intubation may have been a particularly stressful assault on some of our patients. So I'm going to start there and just say, hey, look, I think everyone's tried to work as hard as possible. This was a wallop, and it was a wallop for everybody. We're doing a great job about learning. And I think, if we get lucky, we'll have a great vaccine or several great vaccines. Logistically, we know it's going to be hard to get that vaccine to everybody. So there's just a ton of, we got to be patient. We got to hold our breath. Luckily, governments have responded with putting capital into the economy to kind of stabilize things. So I think in many ways, we should take a deep breath and say, I think we've made it over a lot of the hard stuff and that initial kind of acute phase. Now there's a chronic phase, which could in some sense be harder and may make it tougher, and everyone's lost their patience. And so we got to kind of find energy to do that. But I think long term, look, we're all in this together. No one's getting out of this, on their own, right? So we got to work together. We got to share data. We got to figure out what works. And everybody wants to get over with COVID. Nobody wants to hear about COVID anymore. Everyone's tired about hearing about COVID. We always hear about something else. But we need to keep that going in order to solve the problem. So
no, I completely agree with you. Completely agree with your point about our health care professionals have done a phenomenal job. They're really having the frontline soldiers, and they're really
even the community people. I mean, I've actually been so overwhelmingly positively surprised. People really listened. People stayed home. People didn't go out. People educated their kids at home, as hard as that is, and try to do their job and try to go on Zoom. I mean, it's been really pretty incredible to see how well, given all the things, we've handled this. And luckily, we have far fewer deaths than we could have had from some of the models. That's a wonderful thing. And I think the biggest challenge now is, how do we move forward in a distributed way, which is what you need in a free society. People got to be able to kind of come and go and be able to make decisions and so on. And at the same time, if you need to really make a change, able to get that message out. Because I think part of it right now is like the horses are out of the stable. Every state's doing its own thing. Every kind of country's doing its own thing. And so we're out. And so we've got to really think hard. If there is an important message, how do we get that out there? And if we learn something about the disease that fundamentally changes our recommendation, how do we get that out there? Otherwise, I think we've just got to keep our nose to the grindstone as scientists, get a vaccine out there as fast as possible. And Gates is betting on multiple vaccines. I think that is the way to do it, and others are as well. And then try to keep the calm and just really reassure the public that it's a slog. We're working as hard as we can. And as soon as we get a vaccine out there, we'll get it to everybody. In the meantime, please protect yourself and be kind to people who have to protect themselves. I think that's.
I'm gonna stay provocative, and I'm gonna frame that question back to Sumant, because that's part of my job as a moderator here. So I love the optimism and the positive stories that you pointed out, Carlos, and I completely agree with that. This has been, I think everybody's been together. The extent to which even folks that are daily wage laborers and as far away as in rural India have actually followed the stay-at-home restrictions despite substantial impact it has had on their livelihood. So Sumant, the same question that I asked Carlos, why have we been so surprised? Even with the success that we did have in maybe managing the number of people that died, and I think everybody sort of stepped in, especially in the developed world healthcare system.
Yeah, so a point that Carlos made was very good about how we have behaved in light of this, but that was a reactive behavior. Mm-hmm. So how do we flip to a proactive? I was reflecting back that as much education I have been involved in through my career, I never got a lesson on the pandemic of 1918. Never. I knew it happened, like in medical school, you learn about it. And, a communicable disease like a virus or a bacteria or fungus, these are communicable diseases. they tend to be drama. They come on, they surprise us, and the non-communicable disease are these very, very long and boring soap operas. They just go on and on and on. And we have to tackle both fronts. And when we talk about the future of healthcare, we need to pivot to proactive natures of preparedness for communicable diseases, because Carlos is right. They're going to come back with global travel and the way we all operate today. It's coming back, not necessarily coronavirus, it could come in another form. So how do we make sure that we are proactive in this process? And I do believe things like digital tools do help here. Most of us have a device that looks something like this, like a phone, okay? And how do you have the type of sensitivity in answering questions or submitting data? The other point Carlos made is very good. We need to share data. Earlier on, it was unclear what the real data was, okay? So you can't necessarily always respond when it's unclear, it's fuzzy, okay? Because you don't want to alarm the world. So having clarity of sharing data amongst governments and NGOs really helps a lot, okay? So that's really critical for any communicable disease. So in the future, we have to learn from this. We do have to teach people, because anything that you are going to be good at, you have to actually exercise, okay? It's like any skill, okay? And when you exercise that process, you become really good at it. So being prepared for a pandemic is very hard because it doesn't necessarily come every other year or every year. We think a flu pandemic will arrive sometime. What does sometime mean? My lifetime or after my lifetime? So we actually put it to the back burner because there are more pressing issues. So I would say that we were not as well prepared from a proactive perspective, but I think we did the best to react to the situation from all the frontline workers, from all the citizens across the globe saying, I will stay home because it's for the best benefit of society as a whole. But that's not the best answer.
No.
The best answer is being proactive.
And I really love your comment about preparing for this. And I think I would really frame this in the context of the new normal, right? In terms of just things that we need to be prepared for. In the same way in California, we have to be prepared for wildfires, right? We now are for whatever reason, we're in a period of time when we're just getting walloped by wildfires. In Florida, we get walloped by hurricanes. You have to be prepared for it, right? I lived in Florida. I lived in Miami when Hurricane Andrew hit. It was disastrous. But boy, after Hurricane Andrew, everybody in Miami has been much better prepared and, knows when to evacuate and how to get things done. When we had the Napa fires, 2-3 years ago, it was devastating. It was just absolutely devastating. The fires last year were actually worse, but most people fared a lot better. Why? Because they were prepared. They had gotten fire engines. They had gotten their property, degrassed and so on. So there's a lot of this, which is, let's not get caught again like this. What do we need to put in place in order to prevent this in the future? And that, I think, is the most important part to get right. Otherwise, it really will be just an incredibly unfortunate, sheltering in place that didn't change anything, and we just keep doing the same thing. And that would be
hopefully we are learning. And actually, that's a good segue to the next question. And both of you talked about this. Sumant, you talked about data sharing and how abysmal that has been to a certain extent. You also talked, Carlos, about how we have all done our own things in various states within the US, but also we've done our own things in various countries. In some ways, it may not have been so bad for us to have done different things in different countries, and I'll come to that in a minute. This is not a disease that is going away in the next 3 months. There is a likelihood that there may be second or third waves because vaccines are not going to be here in that duration. And even if they were here, mass administration of this to 7.5 billion people, that takes a long time. So we will see future waves potentially. Looking at how China has dealt with it, how Sweden has dealt with it, how we have dealt with it in different states within the US, what are the lessons that we have already learned in the spirit of learning lessons, Carlos, to the point you're making? We as human beings, one thing that we are supposedly good at is we learn from history, right?
Yeah.
Supposedly. What have we learned so far looking at everything that has happened? Granted, the whole story has not been told yet, but what have we learned?
I'll give you one lesson I think we definitely learned.
Complete the question.
Okay.
How does those lessons translate? How do those lessons translate to Brazil? Because I would love to kind of bring that, because a lot of our listeners are from Brazil, and Brazil is going through a pretty difficult time right now, and it has done the best it can given the resource constraint that it faces, and yet hope is that we learn quite a bit. So what are the lessons? The two-part question: what are the lessons that we have learned from these different models in different states, different countries, and what could Brazil do things differently as it moves forward?
So I would say the number one lesson we learned is the importance of keeping the healthcare workforce safe. Yep. Once that went, that made it impossible to maintain control, and it also highlighted what was a particularly pernicious aspect of this and most communicable diseases, which is that hospitals become transmission hubs. And so even the testing went kind of in the wrong direction. We sort of said, only come out and get tested if you think you're really sick and it's positive, and only come to the hospital if you do that. That ended up aggregating cases and probably making the spread of the infection worse. What you need to do is aggressively test and contact trace, right? As we know, you want many more negatives than positives. That allows you to sort of circumscribe the positives. I think we've learned that. I think we're going to try to do a better job on that. It's a tough problem. I mean, it's not an easy one to get ahead of. So, but I think we've learned that lesson, and I'm really optimistic that we will really reduce the foot traffic in our hospitals. That it's something we've just been learning since the Civil War. Okay, the fewer people we have, the better.
I'll follow up on some questions about that specifically to you, Carlos, but please go ahead.
But I think we have to really redesign and really rethink how we deliver tertiary and quaternary care and elective surgeries. That should all be distributed. We should be testing a lot more for elective surgeries, which we're seeing now in the United States. Hopefully Brazil will be doing that as well. And as I say, we're testing now for COVID. Hopefully in the future we'll test for other things. If you've got H1N1, we also don't want to do that knee replacement. We also don't want to bring you to the hospital, right? And so I do think we're going to just have a lot of sensitivity around that. Part of that's business in the United States. Our outpatient business is down 70, 80%. Hospitals are bleeding money. This has been, they're furloughing healthcare workers, which is a kind of crazy reality of the situation we're in. So you got to make it safe again. You got to make it safe for people to want to go to the hospital again. And that's I think a big lesson that the hospital administrators will have learned. I think the other lesson is, and this is one that we're ascribing to at Stanford, is try not to do anything outside of protocol. Anecdotal treatment just hurts. And so at Stanford, we really tried to be good about not giving patients drugs unless they were on a protocol. It wasn't like, this is what I feel we should do. That's hard to do. It's obviously much harder to do when you're in the middle of a pandemic. And we were really privileged in not having nearly as many patients as other places. But I think that was an important lesson for us that we are going to want to try to do forward. And then the third lesson, at least from an academic medicine point of view, is to really treat this as a research opportunity. We basically brought the whole medical school around to think about COVID. Medical grand rounds were dedicated to COVID. They've been dedicated to COVID. They're on YouTube. Go watch them. They're phenomenally interesting. I find them. And so that whole kind of all hands on deck, we're all in this one team, put aside your particular, pet projects or pet labs things. This is the most important thing we could all be doing. And that was a really important message for us as an institution to get and to fall behind. I think a lot of healthcare institutions had the same kind of reaction. And ultimately, look, if the healthcare institutions aren't managing the infection, there's not much public health can do. There's not much that government officials can do. And so we are kind of those that at that front line. We've got to be the level heads, and we have one role to play. And we got to understand that. And so the policy is policy, and our role has to be to stay safe and keep our patients safe. And I think we've learned that lesson, and we're going to do a better job going forward.
Sumant.
So I would just say that for a country like Brazil, which has a rich culture and a diverse population, rural through city, some places densely populated, I think in today's world, you have the access to what's emerging in the marketplaces. In some cases, like in the case of Zika, it emerged from Latin America and people were really paying attention to it, didn't quite understand where it was coming from initially. A lot of data sharing occurred. In the case of SARS-CoV-2, it came from Asia and spread across the globe. And I think the governments that tend to do well in general are the ones that listen to where the science is going. And there's a lot of unknowns. I mean, just let's be honest. Yeah. When an emerging disease is there are a ton of unknowns. So you do the best, but if you make it as fact-based as possible and you base your policies on that fact base, you generally tend to do better. Now, it's hard to say, hey, New Zealand is doing great. Well, New Zealand is an island of multiple islands, and you can actually block air traffic from coming to that island. It's much harder with porous borders in a place like Europe, where people are going back and forth between countries without necessarily all the checks in place. So I think you have to be driven, scientifically driven and data driven in this process. And the amazing thing about today is, today you, Anurag, and Carlos sitting in California are as far away from me or as near to me as all of the audience in Brazil. Mm. There is no true distance, but a virtual distance today. So if we can take a lesson forward, is making sure that we don't get regionalized in our thinking. Our healthcare providers, our scientists, our epidemiologists, our government policymakers are connected across the globe through virtual contact points and have an open discussion of what we're learning from one area of the world to the other. And be also open when an issue happens in your area, you share that with the world that it is happening, okay, so that everyone else can prepare. So there will always be a starting point of any communicable disease. The question is, how much beyond the starting point can you get to? And even if you get far, can you prevent it from embedding itself in the community so you cannot get it out, okay, easily? So in global travel world, you have to have advanced signals in place, and technology can definitely help with that.
That's great. That's actually very well laid out from Brazil's perspective as well. You both are innovators. You scientists, medicine folks. As you in your own spheres, you're involved in different kinds of innovations. Some directly related to this disease, some maybe beyond that. As you look to the future, what do you think are the innovations, either the ones that you're involved in or the ones that you see outside, that you think will allow us to, control, manage, deal with this disease, but other diseases like that in the future? And Sumant, I'll start with you.
Yeah, I want to think about it more broadly beyond communicable diseases. We spent a lot of time talking about SARS-CoV-2, coronavirus, COVID-19, and I think there is a very, very large health disparity problem in the world, okay? Mm-hmm. And a lot of the health disparity problem that we're seeing is linked to socioeconomic disparity problems, frankly. And so what we need to figure out is, how do you ensure that patients, or people actually first, before they become patients, get access to primary care settings, okay? And if anything I have learned from this process, I used to always say, our products are global. So I work at Baxter, which is a very global company. It spans multiple businesses, from all the way from home treatment of peritoneal dialysis and nutritional products, all the way to the ICU and the critical care patients. And in light of the fact that we don't have drugs and we don't have vaccines in SARS-CoV-2 infections, we actually depend on supportive care products, which the company I work for makes a lot of in that process. But I always used to say, care is local. Yes, health has to have care in it. But in this virtual world, suddenly telemedicine became acceptable. So does it mean that the nurse, the pharmacist, the social worker, the physician, all have to be located in the same country? If telemedicine and true virtual care can happen, is it truly local anymore? You are as far away or near to me as the audience in Brazil. And therefore, if we can give access to care in a way in the primary care setting side that takes basic things in healthcare, when you want to prevent illness, the basic things like obesity, diet, smoking cessation, substance abuse. These things, if you handle them from a preventative setting or address them when they happen, they actually reduce the burden of disease and the cost of care in the system. The other thing is the tenet that in general, the sickest of the patients are the ones that really should end up in a hospital. And as much as possible, you need to treat them in clinics in the community or at home as possible, right? In some countries, that is not the case. They admit into the hospital very quickly, and the cost of care goes up dramatically. So if you want to democratize healthcare, you need to think about these two items. One is how to give equal access to preventative and primary care. And the second is where to treat the patient when they become ill.
That's actually excellent. I have a follow-up question to that. But Carlos, any thoughts on that?
No, I agree. That's where I would go as well. I think it would surprise our friends from Brazil to learn perhaps that in the United States, everything is done at the state level. So when you become a doctor, you're licensed at the state level, right? And telemedicine in the United States meant you could only see a doctor in your state, which is kind of crazy. COVID allowed that to change. Actually, we dragged the country kicking and screaming through 5 years of telemedicine in a month and a half. Hopefully we won't go back. Partly because, again, it's this issue of reducing foot traffic to the clinics, moving more from reactive to proactive. I do think ultimately it's about people making decisions themselves. And so what you want is to create healthcare systems that are so good that people want to use them. People want to pay a monthly fee to be a member of them, kind of like a gym, kind of like, the way health should be, that Google and Apple produce a health product that is so wonderful. It's tied to your phone, tied to your subscription. It helps manage your medications, all that wonderful world that we're being promised. And I do think this will move us in that direction. My sense is like most Pareto things, 80% of health is like what you eat, getting good, clean water. If you need to get on a statin, get on a statin. And if you need metformin, get on metformin. And my guess is that takes care of a lot of things for most people. And then, if you get cancer and need specialty care, then things get really expensive. So there's a massive amount of knowledge inequality. I think it's a little bit less socioeconomic inequality. I'm not sure how much it's tied to the amount of dollars or reales in your pocketbook. It's what you should do to stay healthy. There's some great grandmothers out there that have much better health plans than a lot of executives and lawyers I know in terms of how they eat and how they don't smoke and how they don't, have a stressful life and stuff like that. And I think all of that we should be doing and promoting. But ultimately, a lot of the costs, at least the costs in our country, have more to do with the extraordinarily intensive kind of medicine that we practice. And so again, kind of being realistic, if what we care about is, lowering healthcare costs and what that's going to happen, in some sense, healthcare is now the US #1 industry. I think retail places are going to turn more into healthcare. We're having an aging population. And so we have to kind of get prepared for the fact that there are going to be a lot of sick Americans. How do we take care of ourselves? How do we take care of each other in a really reasonable and good way and create opportunities for innovation and incentive? So my sense is that COVID helps in a lot of that because it moves things rationally and capital will chase rationally. But my biggest worry is, of course, the massive inequalities and how long the country can last under something like that. And so at some point, we're going to need to come up with a much better solution with a basic net for everybody. And that's going to be the big issue of the 2020s in this country, how we do that.
Well, I'll just take that on. I think health inequity is something that was one of my questions that I did want to tackle. I'll come back to the health inequity question. Before I do that, I have a business question. Sounds like a crude question in light of inequity that we're talking about, but it's the reality of healthcare, right? I've been having these conversations with clinicians, my friends who are actually at the forefront of a lot of technology innovation and adoption of that innovation in the healthcare system in the US. And one thing that they often, they're very pleased that, this crisis has been a pretty bad thing for our society, but it has actually really brought about changes that were taken 5, 7, 10 years. It's been really shifted to the left, the adoption of many of these telemedicine technologies, remote care, and things like that in a pretty substantial way. I mean, many of my surgeon friends actually get up in the morning at 6 and they see their patients when the patients are at home as a pre-op, and then the patients come in and for the actual procedure. But a lot of pre-procedure engagement is happening right now through Zoom and other online platforms, right? So the health inequity has been a hallmark of this crisis as well. I think people who have really perished, other than our healthcare workers, which are really brave for frontline soldiers, it's really been old and the ones with a lot of comorbidities and those whose health has been immune compromised, right? So going back to you, Carlos, what's the future design of healthcare system that would bring health equity to all of us? I mean, I'll say one last thing quickly. You may have all read the book by Eric Topol, which talks about deep medicine. And his point he makes is that the medicine that we practice today, at least in the US, is a bit shallow medicine. It has gotten shallower. And I think, Sumant, you talked about leveraging of use of technology in ways that hasn't been, people-centric or human-centric, right? So one chapter that's missing in that book, I think, is deep equity. So we talk about deep medicine and deep a lot of other things, but what about deep equity? So what's the future design of healthcare system, and what's the role of technology in bringing that equity? And so I'll start with you, Carlos.
Yeah, I mean, I like to really talk about what a floor should be. Equity, especially in a market-driven economy like the United States, is just a hard thing. I mean, what does that mean? But I think we can talk about a minimum. What is the minimum things that everybody should be guaranteed and have access to? And I think that where this goes is through the data. I mean, the data for some people, their healthcare data is some of the most valuable assets that they hold, and certainly for the poor and sick, that is unfortunately the reality of the situation. So we've always kind of had a social compact around that, right? Most of our academic medical centers provided free care in exchange. We often set up in the poorest parts of town, and that was how Hopkins and the Hopkins system and the Harvard system and all those systems sort of expanded and grew. Today, I would say we're not like that. There's a massive just variation in outcomes and care, not necessarily even tied to how much you pay, right? Stanford and Harvard and the academic medical centers see some of the sickest people, so they don't have the best outcomes necessarily, and they often are some of the most expensive. But the real challenge is the alignment of incentives, right? So we are incentivized to treat reactively once people are sick. No one pays for dialysis in the United States. That's all heavily subsidized, but actually paying for kidney disease prevention is impossible to do, right? So you actually need the tilt in the direction of organizations that pay for health and want to pay for health in exchange for data. And I think those will be set up and will exist. They've tried a zillion ways of doing this. I mean, this is not a new idea. HMOs have tried to do that. The next, a great idea was this capitated care. We haven't gotten it right because we've continued to kind of, try to intervene and at the same time not provide a kind of universal solution. I think that's going to end. I really do think the US will try to do something. I don't know if it's like VA for all. I don't think that's what people want, but that is the one system where we actually have hospitals. I don't know, but we're going to need to go down some route like that, either that or vouchers in the way that we do for Medicare. So the fastest growing part of Medicare is Medicare Advantage, which is just a transfer from taxpayers onto privately managed programs. That also exists in Medicaid, and every state has a Medicaid program, right? It's what the state law does. So I think you maybe go through the Medicaid program and you provide a minimum through there that would include telemedicine and all your meds and stuff like that. But it's hard to know. Part of the freedom afforded in America is the freedom to make lots of mistakes, and so different organizations may get it wrong. But I think that's all that comes to mind.
That's well said, Carlos. So what do you think?
Yeah,
what
so
sort of
just a few things. One is that I want to pivot it to emerging markets, Brazil and other places, where I think there's a different kind of challenge. So in many of the markets, if there's a public healthcare system, it should be disproportionately tailored towards preventative medicine, checkups. It should be screening for common cancers, colon cancer, breast cancer, prostate cancer, the more common ones. It should be focused on smoking cessation when possible, psychiatric diseases, which are quite common across the global population. Frankly, as we get more and more isolated, it has actually increased. It should be focused on obesity, exercise, diet, and the screening processes that occur for diabetes, for hypertension, and intervene as early as possible. I think you can truly bend the curve of the public market costs, okay, through this. That's number one. Number two, in most markets, there is always going to be a private segment in general, okay, because there's a subset of the population who can afford to pay the extra dollars to actually get the different type of care. So of course they have access to public care because they're a citizen or resident of that country, but they opt to pay for some other type of care, whether it's out of pocket or through private insurances. And that does occur. And there is that private segment that you can't say, I won't let it happen. I will let it happen for those of folks that can afford it. But to be equitable, you have to have it as equity in the broader population. And you have to start with essentially the patients or the people through preventative care, early screening, early intervention. I want one example to be given. I got a text today, a series of texts actually, someone saying from an emerging market that their mother had breast cancer and metastatic breast cancer. And the doctor offered them the 2-drug regimen, which is adriamycin and cytoxan, cyclophosphamide, or the 3-drug regimen, and the patient is HER2 positive. That means you could get Herceptin, trastuzumab. But the 3-drug regimen was 5 times to 6 times more expensive, and these people can't afford it, than the 2-drug regimen. But the outcomes of the 3-drug regimen are much better for a HER2 positive patient.
If it's your mom, you want her to get Herceptin.
Yes. But that is the definition of healthcare inequity. And I want to say that point because I have a series of texts from a friend who has to make a choice. Okay, so if you truly want to impact the population, you start with population health. You start with preventive medicine and early intervention, and you save those precious dollars in the public markets for those extreme cases. If you try to intervene when the patients are really sick, it'll sop up every single dollar, and it becomes a vicious cycle because you can't get people out of the system, and they keep getting sick. And so for the public markets, if you want equity, you've got to start early.
There's some striking numbers on this. So if you ran an insurance company, the 5% of the people on that insurance rolls, the top 5% would eat up half of the premiums. Mm-hmm. It's that skewed in
end of life care.
And it's mostly end of life care. It's mostly end of life care. It's mostly part of a discussion we need to have in this country about how we want to go.
So I'm going to switch gears and I'll ask one last question before I switch to audience questions as well. So this is more focused on the future. As you look into your crystal balls, both of you, look at post-COVID-19 world, the new normal as it's being called. What are the promising innovations for the future, both on the drug side, Sumant, from your perspective, and on digital health and connected health, as we're calling it at my organization, Orbis Medical? What are the innovations that you see that would define the future or would be the most valuable new things in the future? And if I'll add a Brazil layer to that question. As entrepreneurs and businesses in Brazil that are in healthcare business are thinking about investing the energy and time and resources, what should really be they investing in?
Yeah. So few things. One, actually, as Baxter, we actually span medical devices and pharmaceuticals.
Yep.
We do have a group that does diagnostics from an adjacency perspective, just to make sure we identify the right patients to put on therapy. So a few things. So you're right about interconnected health. When possible, and we deal with the sickest of the sick patients, so we're not in that preventative medicine situation. We are in injectable drugs, therapies in the ICU, therapies at home for peritoneal dialysis, and IV nutritional products, and a whole bunch of other interventions on the sick patients. So I'll speak from that perspective. So number one, from a pure perspective of how we think about it, digital health is critically important. The interconnectedness of data, okay, is really important. So for example, I'll use an example of peritoneal dialysis. A patient is at home, they're getting peritoneal dialysis, but we have a digital health program that connects our APD cyclers, okay, to the doctor. But how do you capture weight? How do you capture blood pressure? How do you capture temperature? Manually, or is there a way to do that checkup in the morning and evening? Because these dialysis patients, these kidney failure patients, are prone to all three situations, okay, where weight could say more fluid, hypertension, blood pressure, temperature could indicate you may have a fever and infection. These are immunocompromised patients. Let us intervene. You get a call from the nurse and say, let's intervene at this point. So the early point of intervention, as much as possible, is critically important. I'm going to flip over to the ICU. In the ICU setting, you have patients that are getting monitored through several monitors. Frankly, the number of beeping and noise in the ICU, okay, thankfully the patients are sedated. You won't be able to sleep. It's loud, okay? But how can you cross-correlate the data from all these systems? Because they come from different companies.
Yeah.
But if there's an overlay of data from that system, you would be able to do much more predictive analysis. It doesn't take the physician or the healthcare provider out of the equation. AI doesn't replace the healthcare provider, but the healthcare providers that do not practice the AI processes will probably get replaced in time. So people who understand the field, understand how to use data and information and knowledge, will probably have a bigger impact in healthcare than those that do not.
That's great. Carlos.
I'm going to go to the same three places you went. So I'm going to go to critical care, I'm going to go to chronic disease, and I'm going to go to at home. I think that for me, I've wanted to disrupt infectious disease for years. I think we've been practicing this the same way since the 1920s. At-home diagnostics will be a thing. I've always wanted to be able to like screen my blood at home and know what I got, and I think that'll come by hook or by crook. I think telemedicine is going to be probably one of the most important things against the battle of mental health that we've got. The whole getting people comfortable to talk to their doctors online, to be able to do therapy online. It scales. It scales much better than in-person visits. It allows scaling of nurse practitioners who are digital. That's going to be a whole area that we need to fill, similar to in how genetics, we invented genetic counseling. You need kind of like medical counseling coaches, and the nurse and nurse practitioner world is kind of perfect for that. And you can be monitoring patients. So I love all that. And I think that's definitely coming. On the chronic side, I think COVID's teaching us what we knew. It's all about inflammation, managing inflammation and managing thrombosis. And that's just going to be a problem everywhere. It's a problem at home. It's a problem in the ICU, and it's a problem in the chronic setting. So we just got to get better at it. And I do think this idea of routine monitoring and immunomodulation, we're just going to get better at it. We've got to do it in a whole host of diseases. As I like to say, if I think about the biggest, selling drugs and the, anti-inflammatories, might I also consider them antipsychotics, right? If they take your pain away and your chronic pain away, do they, just prevent all kinds of other issues? And so I think we're going to get a lot better at managing that. And COVID is just going to be the door that opens that all up for us, as well as the differential response of patients to infection, which we've known for a long time. Critical care, I hope to God we start sequencing all of our patients who are intubated. Why on earth are we continuing to treat pneumonias all the same way? Okay, BioFire is great. I love BioFire. We need to do lots more of that and other things. Okay, had we been sequencing our pneumonia patients, we would have caught COVID in January everywhere. Okay, and I think it is going to become part of what we need to do. We've proven out how important sequencing can be in the neonatal and the NICU, PICU. I think we'll do that in the adult critical care setting, particularly in the management of infections. And I think long term, data is a stream. Okay, there's this notion that I'm going to go out and I'm going to aggregate all this data. It's like, well, not sure that's all that's going to do for you. What you need to be able to do, though, is exactly what you mentioned, which is that at a given point in time, bring data together to make a decision or to give early warning. If I could have a blood test that would predict who's going to get ARDS in 24 to 48 hours, that would be really valuable. Why? Because we would treat the patient differently. Okay, and that's where we need to really be moving towards. And what I like, a preponderance of evidence. I like my algorithms where I have like 30 features that all tell me something's important and I can drop half of them. That's awesome. I don't like overspecified models. And so this idea that all of the beeps and the alarms need to be in a symphony going in the same direction, something we've got to learn, because so much of the problem is we've got misreading of signals, right? And this is what's happening in ARDS COVID management, right? Should we be upturning IL-6 or downturning IL-6? I don't know. It depends on the patient, right? So that's what I think is going to be really important. It's going to teach us this. I need to understand what patients the disease has, and then for a given patient, how I am most likely to optimize based on the patients I've already seen.
Great. So we have 3 minutes left. I'm gonna have 2 questions from the audience. There are many questions, but 2 that I'll frame in those minutes. Carlos, this is for you. What will be the impact of this pandemic on medical professionals of the future? There is a higher demand of healthcare workers, especially in Brazil, but there's a shortage at the same time in Brazil of medical professionals, and there's a high cost of training. What's the approach to address that?
You're going to split between those that are largely digital and those that are largely in person. And we see this in pathology, radiology, genetics. There's a whole kind of, world of clinicians that may end up providing care online. They may just not be laying hands on patients. I think the big challenge is, how do you do medical education that really requires a lot of inpatient training? You've got to touch and handle patients, even if they end up practicing mostly online, which is what I would venture to guess. Any 22-year-old doctor today, a lot of their career is going to be spent managing patients online through WhatsApp, through a zillion different devices. And so their whole careers, in the same way that we invented them in products and services for the internet that haven't been created yet for digital medicine, that will exist and will need to exist in order for that transition to happen. And they're going to continue to concentrate the life and death decisions in smaller and smaller hands, because those will become much more, weighty decisions to be making if you're able to really, do a good job of reducing the deaths. Fascinating.
Sumant, last question to you. How does Baxter see the role of company? Actually, let me back up. Patients are becoming a really critical piece of the customer puzzle. They are becoming part of the customer pool, just like the healthcare professionals in the hospitals. So in light of that shift that we've seen during COVID-19, how does Baxter see the role of the company both during and post-pandemic in medical education, medical advertising, and how you approach customers? Will that change from conventional sales channels to more digital? Any thoughts on that?
We're already seeing a shift. So a few things. One is that we have to, as any company does, have to respect the time and space of the clinician and what information is valuable to get to them. Number 2, how do we get that information to them? And I actually commented on this when I saw a post about the fact that there was a doctor from Europe, a doctor from China, and a doctor from Singapore on a global WebEx talking about their ICU experience with COVID-19. And 3 different areas handled differently, sharing ideas with the world. and Baxter had put the group together. And so when you think about the downtime that occurs when you have to go to the airport, travel, get on a plane, go to a convention center, book into a hotel, and then show up the next day and look all bright and cheery with a tie, maybe a jacket, and then give a talk, and then do a few more things, and then get back on the plane and go back to your country. We are now seeing global exchange of thought leadership that we have never seen before in this manner. But I think it's already changing. Number two, conventions are really important, but the way they were set up was in large convention centers. Anywhere from 1,000 to 30,000 people would show up, and then they would exchange information. A bunch of it was around socialization, which is clearly important, but the question is it really important in that setting? And then there would be some lectures, and there'd be series of lectures. Now these conventions have moved online, and you click to the sessions you want. So I wonder what the cost of going to a convention becomes in that virtual setting in that process. Now, obviously, conventions and things like that help the economy. Hotels get booked, restaurants get booked, taxis get booked. I'm not trying to take away from any of that, but I think we have to ask about the efficiency of information exchange and how we can drive to a better outcome in the process. So I think some of these changes are occurring, and some are not very replaceable. If you have to go in an OR to help choose the type of product or train people, you have to do that, okay? If you have to ensure that you're rolling out a new technology, you just can't put a technology out there. There's a change management process of putting a new technology out there so that people understand the maximal utilization of that. So where it is the most important, human-to-human contact should absolutely occur. Where we can question whether it needs to occur, is there a process of building a relationship that drives further value than we have tried before?
Excellent. Well, that really covers it for us, and we are spending almost right on time, a couple of minutes over. Thank you both so much. I took lots of notes actually as you were talking, so lots of lessons learned for me personally, and I'm hoping our audience learned quite a bit as well. Wish I had more time for audience questions and for I had a lightning round set up for you guys, but maybe next time. Thank you so much to both of you. I'll hand this back to Diego. And just great conversation. Thank you so much.
Thank you.